Hello, everyone. Let's start. My name is Marina Sheperek, Head of Talents of Qubit Labs. Qubit Labs is an Ukrainian IT company, partner for tech industry product leaders all over the globe. We build developers teams for top companies and innovative startups from USA, Europe, and Middle East. Our clients are developing products in gaming, fintech, digital, media, logistics, and of course, health sector. Healthcare is a very trending topic nowadays, so we decided to invite our partners from Avydium to discuss healthcare digitalization trends. So please let me introduce our first speaker, Dr. John Stagl, President of Z Systems and Medical Director of Avydium.
Thank you, Marina. Hi, I'm John Stagl, and we're going to talk today about the transformation of medicine. Wow, that's big, but I'll tell you, it is exciting. It's exciting until I say that. It basically is going to, one moment, there we go. We're going to be talking about healthcare administration. So then all of a sudden you think, okay, healthcare administration sounds like a bunch of suits sitting around a big table trying to decide where the money is going and how much money is coming in and all that very, very boring stuff. So you might want to ask, what does that mean actually, healthcare administration? So as a physician, I'm not going to talk to you about all the new advances in medicine. I'm going to talk about things that refer to the efficiency of rendering effective healthcare, not how well we get people, how people, get cured, but the actual rendering of effective medicine. So why is that important? Well, the goal is to consistently improve outcomes in all directions. And why should it concern you? Well, obviously, we are all patients and deserve the best possible healthcare. And so this is our mission. But we're talking about healthcare administration. I think it's a little misleading. So what I'd really like to talk about is more about process management. And it really is exciting. It is exciting because we're looking to enhance healthcare delivery. And today, there's a challenge with that. For example, I just actually scheduled a visit with one of my doctors for, just a checkup. And that process was, multiple phone calls asking me to, come in a half hour early to fill out forms and go online and fill out some forms, which was fine. I would rather just fill out everything online, and hopefully that would just go, being that it's digital, go right into their electronic medical records. But no, they went online and all they asked was, my name and address and little things like this. And I got to go in a half hour early to fill out forms. And, this is really, really old. It's slow and cumbersome. So when we're talking about the actual delivery of healthcare, there are a lot of moving parts. So let's talk a little bit about that and how we're going to solve that problem. So basically, we have the first part, which I just briefly described. Is the patients go in and they fill out forms. And this sometimes in medicine, we refer to that as the discovery process. And we all know how that works. Put your name at the top of the form, you fill out a bunch of things, you sign the form, you date it, go to the next page, put your name at the top of the form, put the date on it, fill out a bunch of questions, you sign it and date it and go to the next page. And this could be 2 or 3 pages or as many of maybe, 12 or 15 pages, depending on the specialty. And, so that's what we all have been going through. You got to wonder, there's got to be a better way, right? So the next part of that, it doesn't end there. You have the medical staff. Once you get all that figured out, you go in, you get a workup evaluation. These are the diagnostic procedures and the lab tests we go through. So the staff is involved in that process and doing these things. So who else is involved? Well, we have the physician who actually does the diagnosis and a treatment plan, or if he cannot treat you or is not a specialty, finds you have maybe like a rheumatoid arthritis, he's going to refer you to a specialist for that. And last but not least is the administrative staff. And basically those ones that shuffle all those documents, document management, and they want to get paid, process all this stuff, and the billing. So there's all these moving parts to make all this work. And so, as I alluded to in the very beginning, there's got to be a better way. And we've been doing it this way for a long time. So, a process here is actually going to transform medicine. So, what happens next after all this? So, basically, when you see the doctor, he decides if you're going to get treatment. And of course, he does all the follow up care after that. But if he doesn't treat you or cannot treat you, he's going to refer you to a specialist. So, what do you think happens next? You go to the specialist, and yes, you get a handful of papers and you fill out the forms all over again. Okay. Now, that's not just inconvenient, but think about it. You have all those papers at the one doctor's office, and then you take them to the next doctor's office. Now, of course, they could photocopy those and give you those and take it to the next doctor, but still they're going to want their forms filled out too. But that's typically what happens. So that's one of the things. You could refer you to a specialist. Now, the patient, you might not like the doctor, doesn't like his diagnosis or his treatment plan or recommendation, so they go to seek a second opinion. And again, it's the same thing. You fill out all the papers again, do a completely new workup, and you go through that whole process of all those moving parts. And another thing that happens frequently is that, patients do change. I mean, the world's getting smaller and smaller. Hey, we wouldn't even have a pandemic if we couldn't travel around the world. So, that is the reality of things. So people are traveling a lot. They might actually, I had a patient who fell down, broke her femur, broke her leg in Hawaii. I mean, that really hurts the vacation. Of course, the patient wasn't feeling too well either. So, in Hawaii, now she has to, get all her records together, be treated there, come back home, get treated again. So yes, the mobility of people creates problems or situations that we need to deal with. And, and we're doing that today. That's how we're handling it. So what's the real problem is basically that there's a difficulty in sharing patient data. So I've been involved in electronic medical records for quite some time, over 20 years. In fact, not bragging, but I developed one of the first electronic medical record systems back in 1989 because I knew there was a better way then. And we digitized things and made it a lot easier. I hated dictating, so I created a system where I didn't have to dictate anymore. But fact is that was proprietary to my office. That was my computer. That was all my information. So sharing that data, is doing it the old way. Print the papers up, take them out analog, take it to the next doctor's office, and that's how that's done today still. Now, being involved in electronic medical records, there is really not a really good, convenient sharing language. There is a language we call HL7. It's very complex, very difficult to use, and if it was any easier to use, people would be using it. So, I mean, it's really difficult, and most people don't use it. But you can connect a couple different systems, but you can't really connect the world. So it still remains a problem, and it's quite difficult. So that's part of the problem. We also have redundancy. You have wasting time and money, and it becomes really, ultimately, it is an inefficient process. So what we're trying to do is we're trying to improve outcomes, make it more efficient, rendering care and getting better results. And lastly, we have a diminished or less than desired outcome as a result of all of that. So that is a huge problem. Now, we have the workarounds. We've been dealing with it, but we don't need to anymore. Everybody talks about the cloud. And the cloud basically is a series of servers that we can tap into now. And what's really cool is we happen to have one of the most incredible computers right in our purse or pocket at this time. They say that the smartphone is 1,000,000 times more effective than all the computers that were used to put the man on the moon. Now that's incredible. We're not utilizing that. We haven't just yet. Yes, there are a lot of apps, a lot of different things going on. But what I'm going to share with you today, I think will blow your mind. It's the natural choice. Okay. So as a result of all of that, yes, we basically have a system failure, and we've been putting up with that for many years. So let's just digress for a moment and talk about a new paradigm. The new paradigm today is, let me just tell you, my mother, God bless her soul, she passed away this last year. She was 98 years old and taking very few meds, and she lived a long time. But to be honest with you, she smoked. cigarettes half of her life, and she never did any exercise, just for the most part. And of course, she probably ate better foods than most Americans, and we call it the standard American diet is the initials SAD for sad for a reason, because it is a sad diet. There's too many processed foods. So people are starting to see these things. They're seeing that, you shouldn't be eating, trans fats and shouldn't be, eating processed foods and more fruits and vegetables, exactly all that stuff. So we know these things, and people are becoming more and more aware of it. So this new paradigm basically is taking responsibility for your personal health. Now, I like to look at it like this, and this is the way I like to explain it. Say there was a moratorium on buying and selling cars. Boom, today it just came into effect. Now, whatever car you have, that is your car, period. There's no buying and selling cars. Kind of like I guess what happened in Cuba. So, so you have this car, and what are you going to do? Naturally, it's like, oh, geez, well, I'm going to have to take better care of this car. So you start researching the ways to improve it. You shine it up, give it oil change, and all this stuff. So you look at ways to maintaining and improving this one car you're going to need for who knows how long. Okay, so we do everything possible to keep that car in great shape, because we don't know when we're going to get another one. Well, the fact of the matter is, you're only born with one body, and that is it. And it's up to you, and that is the taking responsibility of personal health to take care of that one body. And when people look at it from the standpoint is that, I'm not going to get another chance. Yeah, they can put some organs in and things like this, but we all know that's, just patchwork. We got to take care of our own bodies. And I'm not telling you anything you don't know for the people that are listening to this, but this is the new paradigm, and it's going somewhere. And we are basically, if you will, we're going to take that wave to the next level. Okay. We're going to allow you the opportunity to have lifetime ownership of your own personal health data. Okay. So we all know how difficult it is to understand a doctor when he starts talking these big, 15-letter words. We don't understand what he means. Can you explain that to me, doc? What does that mean? Can you tell it to me like in normal language? Not understanding that stuff and wondering what's going on. What do these lab tests mean? All this stuff. So being able to have ownership in your own personal health records, you can do the research. We're all got the internet, and this is how we're connected today. So if you have access to that, it's very easy just to highlight something, boom, and go to Google and Google what this word means. What is he saying here? So this is a very important step in making that happen. And what does that result in is the greater control of your life or your destiny. Okay. Now we can't control when we're going to die. We all know this, and none of us get out of this alive. Okay. But control in the meantime and having the ability to make choices, this is what it's all about. And we give people the choice with some new tools, and that's what we need. So the new normal today is, that's been discussed. Oh, what's going to be the new normal with this COVID thing, this pandemic? Well, I don't even want to touch on that subject because it's not a very happy, friendly looking one. But the reality of things is that typically healthy people don't get sick. Okay. You have to basically be, susceptible to things. And this is why people are dying from a virus, and some people are not. Some people are healthy, some people are not. And it's the last thing that takes them out. So what we're seeing now is that people are taking more control of their health and doing things. So the new normal is to basically do things that are better for you, and namely like regular exercise. As I mentioned, my mother never exercised. Now, she did live to be 98, but and you think, well, maybe all that exercise is not really doing me any good. Well, I know for a fact it does me some good, a lot of good, and it will help other people. And we have a huge problem, and I hate to say it, with obesity. It is a reality in the United States mainly. And it's not just exercise that's going to take care of that, but that's part of it. People that are forward thinking are thinking, what can I do for myself? How can I take responsibility for my own health? And one of the things is regular exercise. And it's just no different than just making time for it in your day. And I know everybody's got their excuse, etc., but that's part of it. The other things, obviously, are healthy diets. We're not going to go into any one of these things, but this is what is changing in the world. People are doing these things today. We're not even close to being there, but we're getting there. You know, you take vitamins and minerals and other supplements and things like this. Maybe some of them are working for you, maybe they're not, but the foods that we have are a challenge. I mean, there's reasons why we don't get the nutrients. I mean, they pick bananas and fruits and that are actually not ripe. They ripen not on the vine, not from the sun, but they ripen in transport. Now, what do you think that has to do with the amount of vitamins that are in those healthy foods? I had a patient once who was exhibiting signs of a rheumatoid arthritis. Now, I'm not a rheumatologist, but I looked at it and thought, okay, let's first thing to do is I examined her, listened to her history, and did what any good physician would do is take some lab tests. I did the lab tests, and most of the tests came out normal. The blood test that I did find out she was very deficient, not critically, but lower than normal in potassium. Or that kind of struck me as, oh, that's kind of weird, you know. Potassium, that doesn't, what's that got to do with anything? So what I did, I asked her about it and she says, wow, she says, I eat several bananas a day. And I go, well, that's a lot because most people don't eat several bananas a day, but I do. I eat several bananas a day. I said, okay, well, let's do this then. I can see the blood test or the lab test results. Let's go ahead and put you on a supplement that has potassium in it and see what happens. Within about 10 days to 2 weeks, all her symptoms were gone. I mean, okay, how do you connect those dots? I'm not really sure. But the fact is that the foods don't necessarily have all the things that they say they have in them. I mean, apricots have a lot of potassium in them, but do they are the ones that you're eating? I don't really know the answer to that. So it's nothing wrong with supplementing your diet. And that's what people are finding out. Just following doctor's orders is part of it, you know, and that's, and I know it sounds stupid, simple, but a lot of people go to the doctor, he says to do X, they don't do it, and that's happened. So we have, again, elimination of poor health habits. We all know what those are. You know, smoking, the things that we do to damage ourselves and hurt ourselves. And it's so easy when you're younger to do the things that are not good for you and still you survive. You wake up every single day. It's amazing how resilient the body is. It's amazing. It keeps taking a beating day after day after day until it just can't take it anymore. And so people are saying, well, you know what? It's maybe not such a good idea to smoke. And maybe it's not such a good idea to overindulge in alcohol and illicit drugs and things like this. So eliminating these poor health habits, even just sitting up straight in your chair is elimination of a poor health habit, okay? Maintaining good posture and things of this nature. So we're looking at these things. And of course, stress has always been a big deal. Stress is well founded that it actually is negative for the body and the chemistry of the body. And we know this. Hans Selye did a ton of experiments and proved it. So we try to reduce stress, be calm, don't worry, meditate. Maybe it's yoga, just making sure you get adequate sleep. It's not one of these, it's a number of them. Good positive social behavior. You know what? Stop screaming at everybody, you know, yelling at people and on the road, get out of my way. You know, it's like, calm down. You know what I'm saying? So, and a nice, healthy, balanced lifestyle. In order to do all these things, there are better tools. And we all know that better tools make life a lot easier. We all know this. I mean, if it's simple as just cooking, in the, you know, and using, I mean, we got a microwave. It makes it easy. I warm up my coffee in a microwave. Or, you know, we have earth movers. Imagine what it took years ago to make roads. People had to dig all that by hand, or horse and buggy. Okay, so I don't want to beat it up, but you understand that with technology, we keep getting better and better tools. And this is what we at Avydium are offering today. We're offering better tools, okay? Some of these tools are just for the patient, like I had already alluded to, is having more control of your life, over your outcomes, over your health, taking care of yourself. and other tools involve the doctor and how he can help you so that we actually work together. So we support each other in the mission to bring about improved outcomes. So it's one hand washes the other. Okay. So the solution is this. The solution is simple. We have provided in Avydium a health data hub where the patient and the doctor have access to the data. Now you might think, well, geez, I put all my information online. That sounds kind of scary. And you know what? There are a lot of people out there hacking and trying to get into your stuff. And, it can be scary, but we built this with that in mind. So going back to where we were before, you go into the doctor's office, they hand you the paperwork, you fill out that paperwork, and then you hand that paperwork back. And here's some of the problems with the paperwork. And this is what we have today. And I just want to drive home the value of what we're doing here. That paperwork resides in a file. One person gets it at a time. You cannot access that file if you are on vacation and somebody calls you and says, oh my God, Ben is in the office, he's having a fit and I don't understand what's wrong with him. What about his records? Can you send them to me? Come on, you know how complicated that would be, especially if you're lying on the beach and you're trying to be on vacation, but you also want to help your patient. All those records can only be accessed by one person at a time, versus that if something was in the proverbial cloud, something was accessible by a tool, something like this. That's very simple. Can you imagine that? That's that little really powerful computer that we all have in our hands. We all have this. Well, not all, but a lot of people have a smartphone and they can access that information. So you can speak basically back and forth to your doctor. The doctor can access your records if we have the right tools. We also have, wearable devices that bring us information as well. And these are all very, very powerful tools. It's simple. With this app, you basically start off by creating an account. Then it asks you a series of questions and you put all those answers in there. Now, it's a bit of a process. It takes some time, but you know what the beauty is? You do it one time. You get referred to a specialist, it's already there. You have to go to another location, it's already there. You put the information one time and you allow access to anybody who needs to see your records by a very, very cool tool. We use biometrics. So what we do here is we take the biometrics and we use that to attach their demographics. So all the data that's in there about you, nobody has any idea who it's about until your biometrics works out. Now, there are a lot of different forms of biometrics. Not a lot. I mean, I don't think anybody's using toe prints, but we have the fingerprint biometric, we have the iris, and then we have the retina scan. Now, there's pros and cons to all of them. We'll start going backwards and lean to the one that seems to be make the most sense, and the pros and cons. Now, because you might think, okay, well, what happens if that doesn't work or whatever? Well, the iris scan seems to be the most is searchable. You can search like 1 million records per second or something like this. And it's as good, if not better, than a fingerprint, because fingerprints can be damaged or worn down. Okay. So iris seems like, well, that sounds great. Of course, you have the retinal scan, which is unique to everybody, but it changes with health conditions. So with diabetes and cardiovascular disease and glaucoma, etc. And to access that is very difficult. You need a special machine to be able to see through the pupil into the back of the eye. And even doctors need to dilate your pupil so that they can get a better view of it. So that has some shortcomings. And then you have the fingerprints. Now, obviously, if you lose a finger or wear off the fingerprints, that's a problem. So in our system, we would like a patient to be able to put in all 10 fingerprints. For that case, it's 10 times better than one. The fingerprints then are much better from the standpoint of, you think the iris is good. Well, with facial recognition software and even wearing masks, you still have your eyes exposed and somebody could steal that data. And I think that leads to a problem. So the fingerprint thing is the phones are ready for it and it works beautifully. So you do those three things, your health record is secure. So the question is it really safe? Now I explained some of it, but let me explain a little bit more. The demographics of your particular file are anonymized and de-identified. And the only time that information is connected is through your permission and the use of your biometrics. So, and then it's shared at the patient's discretion, at your discretion via a unique and proprietary biometric coupler. So the doctor basically, if they wanted to see your file, they log into the system, they ask your permission, you give the sign of a boom, thumbs up, if you will, and he's connected for a specified period of time. So it makes it extremely safe. And that's very important today. So the system was basically designed and built for the ultimate in patient privacy. And it's so important. So how does it actually work? Well, I'm not going to go into all the nitty gritty with it, but I'll explain a little bit with you how it actually works. Basically, there's two sides to our global health data hub integrated into a health data exchange network. One side is that we have the patient's subjective information. That would be if you're a patient, obviously you would build a file and that would be your file. And then the other side would basically be the physician's objective information. So those two things work hand in hand. When you see a doctor, they upgrade your record. And the only thing that you can, as a patient, change in your record would be the subjective information. So you're able to look at the information on the physician side, and the physician can see your side of it. And then we have the two together that provides the whole picture. Pretty cool, huh? So what's the result? In short, the result allows every person or potential patient to have complete control or access over your particular health record throughout your life. And that's a beautiful thing. Again, that empowers you to have more control, gives you a better tool to be able to do the things necessary to maintain your optimal health. Okay, obviously, every physician throughout the world has access to all the patient records with the patient's permission only. So it's very safe. Emergency health information may be available to first responders. So somebody could look at your app and get information like, are you diabetic? Are you allergic to penicillin? Any particular things that you would want to share openly with an emergency medical person. So that's very important. And then, of course, if you were to travel, we talked about that in the very beginning. When you go to another country, like, well, of course, they speak English in Hawaii, but if you go to, say, any other country, Brazil, and the doctors are speaking Portuguese, your record is automatically translated into the language or the location where the record is accessed. Maybe the translation is going to get better and better over time, but it's translated enough where they understand things. And a lot of health information, is easily understood in different languages, as we use pretty much the same root system. Now, the nice thing is that we share data in real time, so you never have to wait for somebody to transfer records. Would you send my x-rays over, doc? 3 weeks later, we haven't gotten them yet. Okay, so in the meantime, the patient's waiting, you get a result. So we get faster delivery of healthcare because there's real-time sharing of information. And we have anonymized health data. Now, this is important. That health data can be shared globally to mitigate the spread of infectious diseases. Now, again, it's anonymized. Nobody knows who it is. Basically, it just explains what's going on with the patient, and doctors can share information globally to help reduce or to help actually speed the results. It's a very, very important part of it. And Rom Linhares is going to speak more about that right after me. So he'll explain how we go about doing that with our techniques. And the sharing of anonymized data will improve the overall treatment of disease. And I think you can very clearly see how that can help a lot of people. When you look back just recently, what happened in China, not casting any blame, but something happened across the globe that if we as a say fast forward 10 years, as a people working together, we knew what was going on. Many lives could have been saved. A lot of challenges could have been mitigated. So that's the beauty of it. Overall, the end result, very clear, improved outcomes. Pretty cool, huh? So I want to thank you for taking this time with me. I hope I've made everything understandable and it makes sense. And I hope you get it. I think you do, because you can see where we are going as the human species as we're evolving. So at this point, I'd like to offer an opportunity for some questions and answers.
Okay.
Do you want me to
Thank you
quit
very
sharing my
much.
screen? Go ahead.
Thank you very much, John. We have some questions. First one is, if an accident happened or someone collapsed, are relatives able to access all data or just this emergency health info?
Well, you can access all the data if the patient, obviously, if the patient needs emergency care, the way the system is developed is to allow access to emergency medical people without their actual permission. Because obviously, somebody stole your phone, they would have access to everything if that would be the case. No, we want to give access to things that you don't really, it's not a problem to share, but could be life-saving. Now, once they enter the hospital, we may be able to facilitate the availability of the access to the other records, but bear in mind that if the patient is not conscious or aware and cannot acknowledge giving access, then they're still under emergency care and they would be treated as such.
Mm-hmm. Understood. Thank you. One more questions. If government and insurance companies will be able to access some data?
Yes, that's part of the whole process. I think Rom will be speaking about that and how we share that information. The information they'll be able to have access to would depend on, obviously, on their need to know. And the idea is to have a better process of submitting claims, better process of understanding what's happening globally for the benefit of people. And that's the whole idea, yes.
Okay, understood, thank you. And then the last question, can we implement this record system in any country?
Absolutely. Now, bear in mind that we are using the latest technology. Well, I wouldn't say the latest, but up to the smartphone technology to make this possible. We're hoping, of course, that underprivileged countries will have access to smartphones in the near future. It is growing very quickly. I don't think we're going to go backwards in that part. The technology maybe remain stale for a while, but yes, it can be used in any country, and that's the beauty of it. In any language, we can have access to this as long as the participant, the patient, has access to a smartphone and the physician has access to the internet. Those would be the basic requirements. Okay.
Okay, understood. And sorry, the last one.
One more.
A lot of countries are scrambling, rushing to put in place COVID, track and trace, applications that use cell phones, and people are concerned about their privacy. How does privacy feed into the solutions that are being offered in the general health and wellness apps on phones?
Okay, well, that's a very good question. And we did cover most of that, but just to reiterate, I do want to mention that privacy is like this. There's two parts to it. We have the data itself about you, and then there's the privacy part is whose data is this? Okay, so if I had hemorrhoids and I didn't want people to know about it, but it showed up that it was in my record, but you didn't know it was me, I really wouldn't care, you see? It's only when my name is associated with the record that I become concerned. So what we're using is the use of the patient's permission through biometrics to couple their demographic information, their name, let's keep it simple, couple their name with the information. Otherwise, the information is basically held secure through an ID that is not necessarily associated with any person on earth. And our system brings the two together. So it is the ultimate in privacy. It far surpasses anything that's I believe that would be available today for those measures. Okay.
Okay, understood. And we have a new one. Can wearable devices become part of the information data that a person shares with their doctors through their solution?
To understand the question, let me just restate it. Can the devices help share the information with their doctors? Is this what you're saying? Okay,
Yes,
so they use
so.
the device as a segue to give the information to the cloud. The doctor logs into the same thing, to the same database, and says, I would like to access Marina's records. And it would be a couple different ways of identifying which one you are. Obviously, if he says, okay, ask patient for permission, the patient gets a response on their phone. If it's connection to the right person, she puts her finger on there, her biometric, to enable that, and boom, the doctor gets the information. And he gets that information, he or she gets that information for a limited period of time. After that period of time, they would have to get permission again, just to keep it safe, so that when the patient leaves the office, that information can't be accessed by anybody else. And the patient could turn that on and off, or give a fixed period of time. This is kind of basically where we're working with this at this point. Does that make sense? Did that explain?
I think so, yes.
Okay,
if we understood the question correctly. Thank you very much. Thank you, John. It was very useful. And please let me introduce our second speaker. Yes, we are ready. So please meet Rom Linhares, Chief Solutions Architect and Managing Partner of Avydium. Ram, we can't hear you, unfortunately.
Oh, okay, I'm back. I hope you guys can see my screen there.
Yes.
Okay, cool, perfect. I'm Brom. I'm the Chief Solution Architect for Avydium. And before I go on to my presentation, which in a little bit I talk about Avydium and what we do, let me try to address some of the questions that were referred to John, and John told that I would cover, okay, before we go on. The first one was on access by insurance and government, right? The bottom line is you own your data, okay? No ifs, ands, or buts, okay? So Marina grants access, okay, to your data, to your insurance company, or to your doctor, or to your family in case you suffer an accident, or something like that, right? So you control that at all times, okay? Access to personal data by a government is only given in the case, and I apologize, I'm looking up because of the screens, I'm sorry, to your data based on public health needs. And public health needs do not need the information in most part, okay? Related to the individual, they are relating to groups or to aggregated data around a particular diagnosis, around a particular infectious disease, or around a geographic area. They are by no means intended to share details of your personal medical history with the government, okay? So we're very keen on that, okay? So you own your data and you determine how your data is shared, okay? But in no case, no instance is the data made available to an insurance company for analyzing Marina as a potential customer or not, okay? So that's one. The other one is the latest act. Yes, 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 yes. Given the constraints of some locations, you have better access to technology, right? Our technology, our solutions, and you see throughout the presentation, are designed with three things in mind before they're actually put on paper, okay? First is privacy and security, okay? And the second one is cloud and mobility, okay? And going back to this is like the concept of sharing everything, right? So, and you will see the data, our data within our ecosystems, let's call it an ecosystem, is shared. There is a common data fabric behind it. So it is a very efficient way of doing that. That is meant so that whenever you're using our electronic medical records or electronic health record or our syndromic surveillance solution, the data is there, and the data is made available based on the need, okay? And based on you being the owner of the data on what you read, okay? So data would never actually be given to somebody, okay, without your consent, all right? So, and the other one is privacy. Like I said, everything we do has privacy by design, okay? So nothing, no data element, no screen, no message, no application, no nothing, okay, is released without being compliant with our primary tenet for development, which is privacy by design. Okay, so now I hope you guys can see the screen here. Any questions on that? John, feel free.
That was great. Yeah,
okay.
Thank you for expounding on that.
And the thing about the emergency is a special different case, and you know, saving a life might actually trump everything regarding privacy. So, you know, that would be up to the emergency care physician to do it. If it is a broken leg or a concussion or something like that, it's a different thing than somebody just passing on someone. Trying to move here, screens. So quick little brief on our history, and this stuff is going to be available anyways. So we started life as a consulting company, and we were focused, I guess you'd say, multiple focus on multiple industries. And as we grew up, we learned that we're really a solutions company. Much more focused on solutions and incredibly focused on healthcare and public health, okay? We have offices in Canada, the United States, Brazil, and Ukraine. Hello to the people in Ukraine. And we have new locations planned in multiple places. Some, you know, are repeat offices in the United States and Brazil, but we have additional offices for, you know, being scheduled for Germany, for India, for Peru, South Africa, Thailand, and United Arab Emirates as well. Like I said, we started as a service company, and we have a deep, strong background in data. We've been dealing with big data even before big data was fashionable. As a matter of fact, most of us in 1996 were working with multi-terabytes and even in some cases, terabyte class data warehouses. Those are the norm nowadays, by the way. They're no longer, just for the big companies right now. So you now have incredibly complex business intelligence solutions that surpass multi-petabyte deployments. We have clients that have hundreds of petabytes of data that they analyze for fraud and for other things. So big data has become pretty much the norm, right? Even before today. Like I said, our focus is in healthcare to a great extent in manufacturing because there is a lot of overlap between manufacturing and healthcare and in government / public health. We're very proud of what we bring to the market, right? In 2019, we actually went through some deep scrutiny of what we were doing and how we were moving. And even through that, I mean, we managed to get selected as one of the 10 most promising enterprise architecture consulting firms in the market, where, again, we're refocusing and becoming more solution driven, and one of the 50 best places to work by Silicon Review. And part of our technology was selected by Time Magazine. Everybody reads Time at least once a year to find out who's the most influential person of the year. And part of our technology was selected by Time as one of the best inventions of 2019. And that had to do with our supply chain management solution, which uses a blockchain component. I'm going to talk, I mean, like I said, embracing Health 4.0. And Health 4.0 is very much intertwined with what is Industry 4.0. Industry 4.0 was a term to refer to this transformation, digital transformation process the industry has been going through. And if you look through it, the evolution of industry, and we're accelerating the time between these revolutions, right? We started way back in 1784. I mean, everybody can read the dates there, with steam engines, right? And mechanized production of things. And they were not really the most efficient things. Then we started going into electricity, and I mean, we discovered oil, and we had machines that moved through, fossil fuel. So we started the mass production. We have assembly lines being put in place. Like I said, we had electricity and oil. And in the late 60s, and people have used 1969 as the dawn of Industry 3.0, which was focused on computing, right? So we had mainframes before then, but it's really that widespread use of computers and the birth of what people called at the time mini computers, right? And the distribution of compute capacity throughout an enterprise. So you started having distributed systems throughout. And it changed the landscape. So if you look at 1969 as being the year that you kicked it off, and you start having really the new revolution starting to come out, and you start seeing the advent of the personal computer, right? Some people say it was the IBM PC, or was it the Apple II? I mean, it doesn't really matter where it started. They started so close together, right? Although I would have to say that Apple II was the first real personal computer, not IBM. But that's me. You guys can throw rocks after the presentation. It's cool. And you started accelerating this, and you start having different drivers behind business and a serious impetus put behind automation, right? Automation of processes, automation of everything. We started having things that were more efficient. And today, I mean, we have things, and today is a fuzzy date, right? You can't really put a date like you say 1969 around Industry 4.0. But you start looking at cloud and mobile, right? I mean, although they are very close together, I mean, cloud has been around for a while. Mobility is something that's a little new, right? Big data, like I said, I mean, we've been working with big data since probably 1993, right? Not really, 2010 or 2014. I mean, if you look at it, people talk about Hadoop is a big thing. Hadoop is not really that new. But analytics, even though analytics have become pretty much the same, the way that we get to the results of analytics have been fast. I mean, they have moved so fast, right? We started having social networks, right, on where we can distribute information. I mean, some of this is fake news, but hey, that's the risk you run with social networks. And you start having serious simulations around manufacturing processes, right? You start having cybersecurity. You have artificial intelligence. Some people will say that artificial intelligence is new. Artificial intelligence is very old. If you think about it, it's work that started back in 1957. But only now we have the computers to actually crank out the neural networks that have been designed back in the labs, back in the 60s even. And we had the same revolution that applied to manufacturing, that applied to process. So I mean, you look at a lot of these things on, like you say, CRM, for instance, like supply chain management, process management. And now you actually have the same thing happen to health, right? And health is very much similar to, and I'm not an epidemiologist, okay, so I'm the first one to say this. It started, the health 4.0 revolution is very much a parallel to Industry 4.0, okay? So this started way back in the 1830s with John Snow and doing, starting the works around public health. And really the first steps towards health surveillance, about germ theory, the work that was done around vaccines and the prevention of disease. Like in the 1900s, we started with mass productions, the big hospital chains, the professionalization of the health professional, right? And the specializations. I mean, back then you only had the tooth doctor, doctor, and a surgeon. Not trying to make fun of you, John. And we started having a pharmaceutical industry start. And in the 70s, early 70s, following the 1969 Industry 3.0, we started having medical informatics come up. So we started having electronic medical records, electronic health records, computing and automation, right? Imaging, all of these things. And with the same speed that you saw in manufacturing, you see it in healthcare, right? You start having the same drive towards, now it's what we're calling intelligent medicine, right? With cloud, with mobile, with big data, with analytics, with social, everything is pretty much the same. Universal integration, I mean, with data going back and forth between systems, and literally at the speed of light, right? And you start seeing things like artificial intelligence applied to healthcare. You start seeing telemedicine. You're starting seeing the health data hubs. I mean, we are not the only ones who have the data hub. There are many data hubs. Our idea is actually a little bit different, which is integration and connectivity with all these hubs, creating a perfect ecosystem of hubs, if you will. And advanced surveillance and blockchain in healthcare, right? The one thing that we see, right, it's the coverage areas that you see between industry and health are very much the same, right? So a couple things that we do is like the wearables and medical devices. I was reading somewhere they're cataloged over 140,000 intelligent medical devices throughout the world. I mean, so how are you going to actually provide interfaces to all of them? So it relies on collaboration between the vendors, the manufacturers, and the users of these devices, obviously. You have an emphasis on precision medicine and telemedicine, on where you can actually get, and one of the best uses of telemedicine that I've seen is you bringing highly specialized medical professionals to remote locations in the planet, right? So you could bring help to somebody in the Amazon or in the middle of, you know, Serengeti or Burma somewhere. I mean, location at this point becomes irrelevant, but dependent upon technology, right? So everything is dependent upon technology. We start seeing advanced content management and analysis. For instance, medical records now can be scanned for, let's just say, congenital diseases, that I can go back and look at not your parents, but a person's parents' medical records to identify additional diseases. And I mean, they don't necessarily have to be called out on the medical record, because I can do cognitive computing or cognitive analysis of the text that is contained on your electronic medical record, right? So I can infer things from the descriptions that doctors have dictated back in the 70s or the 80s, you know, that have been put on digitalized medical record. And I hope it works. Avydium, from our core, okay, we embrace this health 4.0 revolution, right? So much so that we moved from being a consulting firm with multiple focal points around different industries, finance, manufacturing, healthcare, government, transportation, to particularly health. So everything we do, and I mean, this is very important for everybody to know. A lot of people actually claim this. I mean, we actually live or die by this, right? I mean, everything we do, okay, it's based on this common data fabric, right? This common application layer that you see. I don't know if you guys can see my mouse, but it is this up here with the 5 or 6 boxes together. Everything is built with security and privacy by design, right? It is tightly coupled to a messaging layer, right? That is standards driven, right? And we have industry standard APIs, and we have completely compliant messaging layer connection. A distributed management and analytics layers, I mean, that are driven by who needs to look at the analytics, who needs to visualize the data, right? It's really well governed from the beginning to end, right? The ontology is very extensive, and it follows standards, right? And it's a highly scalable data store and data integration layers, right? And it provides the user with a common user experience. So whether you're using the EMR package or the EHR package or Sentinel, which is our syndromic surveillance solution, the interface is all the same, and the definitions are all the same as well, right? So by going to the next steps, you know, Health 4.0, I mean, what are the drivers, the benefits, and the risks, right? Let's start with the drivers, right? I think it is the change of focus on treatment, right? And it is increased relationship doctor-patient, right? That drives this. And it is the focus on the user being responsible for his treatment or her treatment, as opposed to the doctor being fully responsible for a patient's care, right? It's some of the drivers are mobility, like John said, is smart devices, right? And 5G. 5G is going to be a game changer, not just for health, but pretty much everything in the market, right? If you look at it, and I have to turn to look at the data here. In 2019, mobile network traffic was roughly 24.3 exabytes per month. So that you guys get this is somewhere like 24 million DVDs being printed. That's to give you an idea of what this is, okay? In just 5 years before then, our traffic on cellular networks was roughly 2.3 exabytes. So we increased 10x in just 5 years, right? Most of this data is video. It's just traditional data being back and forth. Some audio, and audio not necessarily in the form of phone calls, right? And social networks, right? And it is cloud computing, right? It is the virtualization and decentralization of computing, right? It's the modularization of applications. So now you don't have to write an entire application to perform a task. You actually create these components, these modules that are deployed, right? It's the low latency, the near real-time data connectivity, right? It's interoperability and security between systems. So I have systems sitting in different places in the world, talking to each other and exchanging data based on standards, data based on grants, on access being granted, and fully secure networks, right? Fully encrypted, multi-layer encryption on these networks, right? Then we have privacy. Right now, we actually have privacy is, we say privacy is job one here. You know, it's role-based security, okay? It's who can access the data, right? It's geofencing, so that some countries have safe harbor laws that need to be obeyed regardless of the type of the data, that you cannot exchange data between countries. Like say countries in, just a quick example, Panama, for instance, does not permit data to reside on systems outside of Panama, right? So you cannot move data beyond these geofences, right? And the concept of a federated identity, right? We're still preserving your privacy, right? So you would still have your identity regardless of which place of the country or the world you move to, but you would still be you regardless of where you are, right? But this data could be shared throughout the world, right? Based on your consent, right? And consistency is a major driver, right? 99.999%, when this probably gives you just, if you look at throughout the year, probably less than 20 minutes, right? The other thing is the benefits that you get, right? You have value being added to the whole service chain, the healthcare service chain. You have much better infrastructure around software-defined networks. 5G, like I said, is going to be a game changer. Now you're going to have a network, and 5G is not just putting new towers. It's incredibly complex. But you're going to have the ability to have, 1,000 plus more devices on a network, right? Aggregation, analysis, and sharing of data is going to be done really instantaneous, right? As needed, as opposed to what you had with just a few years ago, and it's no longer the norm of batch-driven integration, right? You're gonna have, like I said, universal integration, because the engines are so exposed right now, and you have things, and I agree with John, HL7 is not the easiest, but there are standards out there like, fast resources for healthcare, FHIR, which is also based on HL7, but it's much, much faster and it's much more open to implementation than HL7 ever was meant to be, right? HL7 was meant to do exchange of data between some providers, yes, but mostly driven to get information from the doctors over to the insurance companies. The insurance companies pay the providers and push the information on remittance back to the provider and said, here, I paid this. That's not the driver. The risks that we have is really pretty much related around the infrastructure, right? So 5G and internet use. And we're lucky. We live in countries on where we actually have this sort of infrastructure available to us, that countries are discussing now, how do we go to 5G, right? When in reality, a lot of the countries in the world, basically have a blackout when it comes down to 5G. When you talk about 4G, some of these countries are not even there. And you really don't have, they just aren't. We cannot assume that because we have the smartphones that the next guy is going to have. And what you have to do is try to bring your technology to a point so far ahead of the curve that you can make the use of your data, okay, the use of your systems available to anybody regardless of the device that they have, right? We do that with supply chain management using mobile phones, not smartphones, right? That we can control entire supply chain networks, complex, going from the manufacturer to the vendor, to the shipper, to the receiver, right? And to the person that needs to get, controlling every piece of the handoff using single mobile phones. And I'm talking about the old flip phones, right? I'm not talking about an iPhone, I'm not talking about a Samsung, right? And there is the distribution, right? What is the percentage of the population that really has access to these mobile devices? I'm not talking smartphones, I'm talking mobile devices. And in this case, I'm talking both, right? Only 5.2 billion, right? With 67% of the world population. And even then, and because multiple people have, single people have multiple devices, right? You have the numbers that you have, 3.5 versus roughly 5 billion on the other side. And in 2025, we're only going to go from 67% to 72% of the world using a mobile device, okay? So it's an increase of only 5% over 5 years. That's not a heck of a lot, okay? You still have a problem with connectivity, you still have a problem with penetration, right? Synchronization of data and services is a major issue. So we actually build our applications to deal with those outages and to be able to work remotely and to offload and synchronize when they reach a network point, okay? Going back to the access to the data, like Marina, only you can access your data or the people that you grant access to, right? The distribution of services throughout the network. And when we look at a network, we look at a global network, right? And the integration between legacy and modern systems, right? We have all the problems that you have with data, and you just have bigger problems because now data is bigger, right? So you have governance and security is a problem, integration is a problem, scalability and privacy. So you have to build things thinking on the 99.999% uptime, right? You have to make sure that things are reliable, they're dependable, and they are accessible, right? So what have we learned from COVID-19 and past crises? First of all, that we have a heck of a lot more COVID-19 experts in the world than we thought that there were, right? So you can't turn the TV today without a guy being an expert on COVID talking about COVID and having no idea what the heck he's talking about. Right? There was a punt on a 3-letter network. Sorry about that. So we learned in 2014 and 2015 that we had an Ebola outbreak, right? And how did that work? It was quickly identified, it was quickly contained, right? And we didn't have a worldwide pandemic, right? We had the potential for that, but people collaborated, right? International health organizations, countries, non-government agencies, they all collaborated and they all got around to getting to a solution, to a containment. You're back, Marina, I can see now. And we didn't learn much from 2014 and 2015 to now. So when COVID came out and we had the outbreak in China, and we can trace the outbreak back to October, and some say even September, right? It got us literally unprepared for it, right? We were going through major technological changes. We were going through some will call a commercial war, like a trade war. We were suffering the effects of globalization, but we were not sharing data. We were not sharing data. Right? And because of the lack of coordination and some confrontational posturing between countries, we missed out on the opportunity to actually stop the outbreak. This could have been a heck of a lot easier on the world and on the world's economy, right, than it actually was. Right? We learned that we are very dependent on technology, right? We forgot, and to this day, I mean, we keep on going back to the centralized bodies for tracking of diseases like CDC and the European equivalent, or the Ministry of Health in different countries. They're not the ones that actually get in the front lines. They dictate, they provide guidance and dictate policy, right? The real public health battles are fought by local and state government officials or provincial officials throughout the world, right? These are the people that need to have their networks supplemented with strong, fast technology, right? That can prevent these things from occurring again. But the effort has to be global. There needs to be communication. There needs to be exchange of data, right? But this exchange of data has to respect privacy. It has to respect all of that. And it's really all about the data. It's pushing the data. So one of the things that we talk about, one of the terms that we use is surveillance 4.0. And that's really why I'm here, to talk about one of our products. And I'm not going to talk about the product. I'm actually going to skip the piece about the product, but I am going to go over some of the concepts that we use on the product, right? This is not about the product. And what we do can be done pretty much by anybody, provided that they want, okay? This is not, it is because we're good, but it's also because we want to do it that way, right? So the drivers are what we talked about, right? For surveillance, I'm talking specifically surveillance, and I'm using surveillance as a subcomponent of the Health 4.0 revolution. Right? It's the need for quickly and efficiently identifying the outbreaks. Right? It's getting in front of these things. We talk about COVID. We're not talking about the other things. We're not talking about dengue. We're not talking about malaria. We're not talking about Zika. We're not talking about measles. Measles is back. It's killing people, right? So the focus is now COVID. I mean, we're forgetting about all these things. I'll guarantee you that public health officials and public health agencies throughout the world are scrambling to get in front of these things. They just don't have the tools. They don't have the tools to get to that. and its ability to use very large data sets, is to make sense of these data sets. Unfortunately, for most of these people, data just sits in silos, and it takes days for them to integrate data. If you look at public health agencies in the United States, which we consider to be the #1 country in the world when it comes down to technology, right? The integration of data, COVID related, which is a major crisis, right? It's still taking between 3 and 20 days. It's now to 3 and 11 days. So the slowest has moved up a little, but 11 days is unacceptable when you're dealing with a pandemic, right? So these things need to get better, right? And data needs to be made more and more transparent, right? Data needs to be published, and it needs to be owned by everybody. Not your data, Marina, but common aggregated data that people can make a decision, right? And there needs to be advanced collaboration. It needs to be the sharing of critical data, the sharing of critical information. But the other thing is what we learned about these accelerators. And we're putting all these things into our products. And they go from the electronic health record, the electronic medical records, to Sentinel on syndromic and sanitary surveillance, to our wellness product, wearables and wellness platform, right? And what we look at, it's really managing the risk, right? And managing the safety, managing the distribution and manufacture of products, right, and food. It's really getting in front of environmental and epidemiologic problems, right? It's getting in front of sanitary surveillance. So in a lot of places, people went on lockdown, but they still produced garbage, tremendous amount of garbage. And a lot of this garbage got thrown out into places because some of the basic services are not available. So now on top of a COVID outbreak, you have a major sanitary problem with garbage being piled up on the streets of some places in the world, right? So now you have all kinds of insects, and you have rodents, and you have, let alone the smell, right? So you need to get in front of all of this, and this has all to be shared, and it has to be made available to everyone, right? I am not going to go to some of this, but I'll just focus on the problems, right? It's the low quality and the high latency of the data, right? The siloed nature of the data, right? The inability to map this data. We have what we call a data console in our application that front ends any and all data that people can make. The rules and the maps are created on the maps to integrate the data into Sentinel. And Sentinel is really a multi-product platform. You have a global platform called Sentinel. We have another one called Scout, which is a little bit lower, and we have something called Shield, which is our very focused on county, local government agencies only. So you have this poor data quality. You have these lacks of standard. You really don't have the same nomenclature across systems, right? On a system, somebody can call a patient, doesn't mean what the other system means about the patient. You have absolutely no control over the data. The data literally changes overnight, and you have to reload the data. And you guys can see by the background. Oh, let's see. Yes, I am in Brazil. And in Brazil, there is the sugar loaf behind my head, the big fat head over there. I can move. No, I can move this way. And that's the sugar loaf. When you look at it, it's taking 20 days. Why is it taking 20 days? It's because of all the steps that data has to go through to reach public authorities. It shouldn't be that. It shouldn't take that long. Because you actually have different processes for that. So if you get to a hospital and you die in a hospital, we know that people died of COVID. If you died at home, it goes to a coroner. The coroner has to evaluate. He may just say that you died, not you, anybody in particular, that you died of respiratory disease, when in reality you might have died of COVID. No tests are being done. So it takes time, and the data is wrong, right? And you need to have a total, complete alignment between data at the, for local, for state and federal level, and you have to have interagency collaboration across countries, right? So if you don't have that, then nothing is going to work. And I'm just going to go through this here on the conceptual architecture of Sentinel. And it's basically all the sources that you can think of. And this is really a very high level view of the application, okay? And I don't call it an application, I call it a solution mostly, because it's comprised of multiple solutions. So data coming from clinics, from hospitals, from research facilities, from medical offices, from pharmacies. All this data needs to be integrated, right? Data coming from environmental agencies, like we have rains and we have the period followed by heat. We know that we're going to have an outbreak in mosquitoes. So most likely you need to prepare for an outbreak of dengue or malaria or Zika or chikungunya or whatever other mosquito-borne disease, right? So you need to get in front of it. So it's really multiple data sets that you need to be able to ingest and interpret, right? Some things can tell you that you have an outbreak of flu even before people being diagnosed by a doctor. People going to the pharmacy, for instance, and buying cough medicine and stocking up on it. I mean, they're either making methamphetamine, that's a different story. Let the police officers worry about that. But if you're selling a lot of cough medicine, odds are people self-medicate. People have a tendency to self-medicate. And if you're selling on a particular area, maybe you're actually getting that area, you might have a potential outbreak of something that may have some upper respiratory disease related symptoms, right? So let's check that out. The other thing is the first defenders, they deal with this day in and day out. They send an ambulance, they send a fire truck, they send somebody to somebody's house, and they're seeing these things. And their reports only go back to their station. They should be going everywhere. They should be going to everyone so that this data can be interpreted, right? So we pretty much gather all this data, and we pick this data and we run it through our platform, right? So we do have multiple, we have one cylinder here for database, but we have multiple purpose-driven databases out there. We have an encryption engine. Nothing goes in without being encrypted. Nothing goes out without being encrypted again. So we actually have, if you think about it, triple encryption points, right? We have a blockchain engine, meaning that you have the immutable ledger of everything that has happened, right? To data, for instance, right? I know how many new cases I have, so people can't go in and just edit the data, right? I have that change track. Or if I'm dealing with medical supplies being distributed on a emergency distribution of individual protection equipment or medication or respirators or whatever it might be, that I can track it all the way from the manufacturer to the person that's receiving it and stamping it and tracking it. Yeah, that's what we call track and trace, right? We have a natural language processing engine that we can evaluate text, right? Do cognitive understanding, do understand what is actually transcribed on a medical record so that we can actually start inferring some additional data from that text, right? We have a transformation engine that integrates very high speed all this data, right? We have an AI-based analytics engine. We have all of our models are wide open. So any researcher, any practitioner that needs access to that data and needs to interpret data is slightly different can go in and edit and modify and keep track of all that history. I mean, we gladly share that with people. We work on any device. smart mobile. And this is very important for people to realize, because in most parts of the world, you actually don't have a smartphone. You actually have just a little flip phone or, whatever system you have. So that people can actually interface with us regardless of the device they have, whether it's a tablet, whether it's a Macintosh, whether it's a Windows, or just a simple Chromebook or whatever. It doesn't matter. We deal with it all. And it's all highly scalable. Like we said from the beginning, this is done with mobility and scalability in mind. We're cloud-based, so if we need to spend more servers, it takes us 5 minutes to do that. Like, not even that. And we are at a point right now that we can trace usage, and we can predict using our own tools that we might need additional servers, so we might spin it up to not have a gap on service, right? And we share all the data back with all those people that provided the data to us and push the data out to additional places, such as research labs, right? Online reports. I mean, everybody's been going through, Johns Hopkins reports and saying, oh, I see this big bubble in Brazil. I see this giant or a bunch of large bubbles in the middle of the United States. Oh, great. But what does it matter to my city? Where are the cases in my city, right? So we actually do all that analysis, and we put all that analysis out, right? We can do individual cases investigation, right? If you guys want to check out on the history of John Snow, the epidemiologist, first epidemiologist, he was a doctor, not the guy in Game of Thrones, please. Not the guy that killed the Daenerys, I was sad with that. We have dashboards. We have to notify hospitals so they can get in front of an outbreak. We have to look at government. We have to push that out. We have to send alarms and notifications to the authorities, right? We have to tell and receive data from schools, right? So if you have a bunch of kids getting sick, if the school communicates, that needs to be passed on to the public health authority, so that we need to understand and be able to get in front of that, because and I was involved in a case like that back in 2003. We were able to identify salmonella case that happened in a school district that visited a pet zoo, a petting zoo. And we traced back the case down to, not us individually, but doctors that were working the case, traced back to an iguana the kids had touched, and kids being kids, they put their hands in their mouths and get salmonella, and that can kill you, right? This is the overview. It's just a slightly different thing. I mean, so you have an acquisition layer. We call the universal acquisition layer, an integration layer. We have a management layer, a services layer, which handles everything, all the AI components, and the use layer, which is the sharing of the data between people, right? And this would be very true to any of our solutions, right? Sentinel, it has deep analytics and very complex data visualization, and we support all data visualization tools out there, whether people are using Power BI, they're using Tableau, they're using Alteryx, they're using pretty much anything, right? They can connect over to our data. We do have our own data visualization layer, but all the data is exposed. So anybody using the system can use that. On the deep analytics side, like I said, all the models are really well documented, and they are provided out to researchers and anybody else doing outbreak detection, right? We do very complex geospatial analysis, right? And we do have our own process definition engine. One of the things that I talked about was the fact that data the process, the definition of these processes for public health need to be owned by the federal and state level, like national and state, provincial level. These processes are defined, but they can be refined by county governments, right? So while I might have a flow like this one here defined for something, a county may make that one either more complete or take parts away that may not be relevant to that particular county. But it's all there. And last, and I can hear people, I can't hear anybody. I can hear people cheering on the back. Yes, he's done. I'm gonna talk about why of the Health Data Hub, right? We call it the Health Data Hub because it is a data hub. It is focused on health, right? And it has just 2 jobs, just 2 jobs. And it has to do those 2 jobs really, really well, right? First, it has to share data, right? So it has to provide a unified care record to providers, right, and particular consumers. I want to be very clear here, not to insurance companies on individual data, okay? I just want to make sure that, okay? But Marina's data is Marina's data, and it's always going to be hers, but it's shared only with the people that she wants to share, right? We'll see. And it's to eliminate the blind spots in care. And that is the problem that you have right now, right? Is if I go over to, I have my cardiologist and I have a problem and I go over to John, and if John doesn't know my history, right? John's gonna have a hard time treating me, right? He might prescribe me, he doesn't know that I'm allergic to sulfur. He might prescribe me something that could potentially kill me. Don't do that, John, please. Not so fast anyways. But it is that sharing of data. And we need to eliminate these blind spots. And that's what we do, right? So we have a very fast focus, a very focused approach to fast implementation, right? We have hundreds of implementation libraries, right? Our APIs are defined, okay? They follow industry standards, right? Our goal is interoperability right out of the box, right? And regardless of where people are using a hub from Cerner or from App, doesn't really matter, right? We're absolutely neutral. We don't care. We don't care what's on the other side. We communicate with everybody. We're wide open, right? We have a very strong foundation on open standards, on standards, particularly open standards. So we're XML based with JSON, HTTP, Adam, you name it, we got it, right? And really, what we need to do is we need to be easy and fast to implement. Right? Yeah, you can't have a hub that makes it difficult for people to share data, or it is only meant to share data within its own ecosystem, right? That's not a hub. It's just a pipeline, right? It's not a hub. So our goal is openness, our goal is speed, our goal is transparency, right? And to grant access to only people that need to have access. Right? So with that, and I can hear people shouting, yes! That was long, I apologize for the length.
Thank you, Ram. We have a couple of questions for you. The first one, what about organ donation passport or the patient's living will directive? Are they available and internationally valid?
Okay, can you repeat the last part? So I got organ donation.
Are they available and internationally valid?
Most countries actually have agreements on that. Typically, what you have on the, and again, it's a personal choice, right? I'm an organ donor, but I actually have 2 driver's licenses, one from the United States, one from Brazil, and the one from the United States, it shows that I'm an organ donor. Mm-hmm. On Brazilian documents, they don't show that you're a donor. Again, it is how you access the data. And if you define on the application that consumer front-ended, right? that you wish to donate your organs. I mean, and some people can specify down to which organs they're willing to part with, okay? And there are a lot of religious reasons for people not to donate. I constantly encourage people to be donors, but I understand those limitations. One of the things that I really think is donor programs need to exchange data, okay? That being said, if they tap into the hub, they could get that data. Based again on that the concept of a federated ID, right? That could be distributed throughout the world. So if that is available in on the data that you share, that's perfectly fine. If not, you know, and I'm not going to go into the religious aspects. I mean, I respect people's decisions to share or not share, you know, on their misfortune.
Okay, thank you. Have another question. Do family accounts exist? Can kids' health data be stored as well? And who can access it? Both parents or not?
And then again, you're actually getting into, again, this is individual, and it is your record is your record, and you define who can, okay? And in the case that, then you have to respect the laws, the local laws. I mean, and when we say geofencing, okay, we actually have to respect the law of the country on where the individual is, okay? So let's look at privacy, okay? You have GDPR, Brazil has LDPR, California has the California equivalent to that. So they are all different, right? So you actually have to see where they are, okay? That's on the privacy. And who you grant, okay? Just because I am a parent would not necessarily grant me the right to view my daughter's or my son's medical records or medical information, because they may, hopefully it's not the case, okay? And they will say, yeah, daddy can see it, okay? Or they will say, no, hell no, I don't want my dad to find out anything about this. It is the individual that dictates that, not the application, right? And we have to follow that. You own your data.
Okay, understood. Thank you very much. So I think that's all about questions. John, do you have something to add to summarize everything was discussed here?
Thank you very much. I think that we covered the patient and the doctor part, and of course the data and analytics. It's a whole package. Everything works together as a unit. You take one part out and it breaks. We need to have just a confluence of data and access the way it should be. I think it's perfect the way it is. Thank you.
Thank you, John. So Ram, do you have something else to add?
Not really, not that I can think. Just drop us a note, drop us a question if you have any questions whatsoever. Let us know. We'll be glad to answer your question. We'll be glad to set up a call if you have any need to discuss anything further. And wide open to that, pretty much 24/7.
Okay, thank you very much. Then I think that's all. Thank you very much for participating in this webinar and for replying to all our questions. It was our pleasure to have such a great guest. I hope that soon we will announce our next webinar, so stay tuned on.
Okay, thank you very much for having us.
Thank you. Take care.
Thank you.
Thank you.
Bye, John.
Bye-bye.
Goodbye.